Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Bruce Werber. Dr. Werber has been a close colleague and friend of mine for more than 2 decades now, and I greatly respect his expertise and insight into many things, but today we're going to talk about regenerative technologies. Dr. Werber is the CEO of BioXtek. BioXtek is a regenerative therapeutics laboratory. We discuss some very interesting aspects of regenerative technology, including what's involved with amniotic fluid, Wharton's jelly, amnion versus chorion, microRNA, peptides, and growth factors. Dr. Werber gives some great insight into this, and I'm sure we're going to be following up with another episode just based on how impactful this conversation was. So without any further introduction, please join us for our conversation about regenerative technology with Dr. Bruce Werber. All right, Dr. Bruce Werber, welcome to the Pod of Inquiry. It's great to see you again, my friend. It's been a while.
And it has. Thank you. Thank you, Steve.
And look forward to having a great discussion about regenerative, all things regenerative today. So why don't you tell the audience how you got into this regenerative arena, and then we'll go from there.
Certainly. So started a long time ago, 1980s, when I came across platelet-rich plasma, and that helped with the wounds, with tendinopathies. It wasn't a real game changer, but it certainly was an improvement. Then along came shockwave therapy, extracorporeal shockwave therapy, and when I mixed the two together, this was a significant improvement in the treatment for plantar fasciosis, Achilles enthesopathy issues, and in treating traumatic wounds and the like. So that was the beginning of my starting to understand regenerative medicine. And then 2007, 2008, I came across placental membrane and looked at the literature, and it was pretty astounding, dating back to 1905. Sabella and then another physician, Davis, both had published papers showing placental membrane in a wide spectrum of pathologies being very successful. So started looking at that, working with a company, and became friendly with a bioengineer at that company. And I said, hey, what if we can make this injectable? And so he and I worked together, and we came up with our first iteration of amniotic fluid with ground up amnion, the amniotic sac. And we tried this on a diabetic patient who was looking at potentially amputation because he was not responding to dialysis. And patient number 1, it was as close to miraculous as anything I'd ever seen in closing a wound that had been greater than 3 years old. And this was a game changer. At that point, I started gathering non-healing wounds from my practice and from my colleagues, and collected the data on these folks, And all 20 in this first cohort, we were able to convert to a healed state in an average of 63 days. Even a venous stasis ulcer, which, as you know, are tremendously difficult, and these responded. So that was the beginning of my experience in regenerative medicine. Subsequently, I said, well, if it's working on wounds so well, what happens if I have post-op dehiscence? And sure enough, post-op dehiscence closed in relative minutes. I'm exaggerating, but it was astounding. And then I said, what happens in an arthritic joint? And instead of cortisone, because I was starting to realize that cortisone was, in all of the corticosteroids we were using were fairly destructive to the tissue. So I injected a couple of patients, and then that grew to a cohort of 20 patients with stage 4 arthritis of the ankle, several post-traumatic pilon fractures, and wow, swelling went down, pain went away in these folks, and even in some of the younger ones, we actually saw joint space widening. And at that point, partnered with the bioengineer that I had met, and with another gentleman, and we formed Amnio Technology to bring this into a business.
Mm-hmm.
And it's been an incredible ride since, working with any number of colleagues, from neurosurgeons to orthopedists, pain specialists. We have now seen an explosion over the last 15 years of case series after case series of both the membrane as well as the injectable allografts, utilizing amniotic fluid and Wharton's jelly.
Mm-hmm.
So it's just been an incredible ride. The knowledge that I've gained in understanding where we thought, it was the growth factors initially. If you recall, with PRP and extracorporeal shockwave therapy, we thought, it's just the growth factors. Mm-hmm. Well, now we understand it's more than just growth factors. It's exosomes, it's peptides, it's microRNA, and all of these components, what I like to call the symphony of regeneration, have made a profound difference. And as I've developed BioXtek, and I now have I have 2 PhDs working with me. Our understanding of the science, mechanism of action, how these birth tissues are actually working, which in some pathologies, which growth factors, which microRNAs, which peptides are doing the lifting for that particular pathology. So, and the more we learn, we need to learn more.
Right.
So it really is incredible. And that we are actually seeing patients improve. So, we had to stop marketing our liquid injectable products about 2 years ago. FDA wants us to achieve a biologics license. And so my company, BioXtek, is on that trajectory to achieve that biologics license, supplying the appropriate information to FDA as we move into our clinical trials, hopefully by the end of this year.
Very good. Well, let's talk about some of the different nomenclature, because this space has a lot of, you mentioned the word exosomes and peptides, and, so let's break it down so everybody has a clean playing field, so to speak, and they understand what we're referring to. So
certainly
you want to talk about, like, when I first started looking at this, I was very early into PRP for plantar fasciopathy. And like you thought, it's all growth factors, that type of thing. But we saw incredible results. I mean, clinically, it was ridiculous.
No,
but then,
I absolutely agree with you.
And then amnion came in, and there was always a distinction. Well, you got to have amnion and not chorion. And, remember, that was kind of the early history. But it seems like it's evolved a little bit. So tell us about, first of all, let's talk about the difference between amnion, chorion, Wharton's jelly, that type of thing.
Certainly. So the amnion, so the sac that the baby grows in during gestation is made up of basically three layers. You have the inner layer, the amnion layer, and this has the most regenerative potential, and it has no antigens, so no risk of any type of graft-host reaction. Then the middle layer contains Wharton's jelly. And Wharton's jelly is kind of a gooey, liquid, highly viscous substance that has lots of variety of cells from keratinocytes, fibroblasts. There are mesenchymal stem cells and lots of hyaluronic acid and exosomes floating around from the cells. And then you have the chorion, which on its outer layer, the maternal layer, does have epithelium that does have some of the maternal antigens. And so that's why we had been making such a big deal about that particular spongy epithelial layer of the chorion, because there was a risk of some type of mild graft host reaction. And it turns out it is very mild. But when we're producing membrane now, we do typically scrape off or shave off the chorion layer, especially the outer epithelial layer, so we reduce any risk of potential graft host reaction. And really, when you look at the literature where people weren't paying attention and they did put the chorion onto, let's say, a wound or a burn, there was a mild inflammatory episode for 3 to 4 days. So nothing terrible. But we certainly at BioXtek, in making our membrane products, which can be used for topical treatment of diabetic wound or any type of wound, post-dehiscence. It's also used to replace pericardium and the dura for the brain and spine. So we're very careful to split off the amnion from the chorion to ensure that we have no risk of graft host reaction. But there are some indications where we have, we can make basically a triple layer where we keep the amnion, the Wharton's jelly, and chorion in one piece. And if you apply the amnion layer on the wound or skin topically, you're all good. For eye disease, we want to only have amnion. So that's the membrane piece of the puzzle. Okay. And separating out those pieces. When we're looking at the injectable version, utilizing amniotic fluid and Wharton's jelly combos, so there's no antigen, so there's no risk of any graft host reactions. And when we look at these amniotic fluid Wharton's jelly, what are the contents? So a good portion of it is hyaluronic acid. And then we have the exosomes. And the exosomes, if you think of people think, oh, exosomes, that's the cure. Well, not exactly. It's what is the cargo in those exosomes. So every exosome comes from a cell, right? So the cell, the DNA, the nucleus of the cell sends out a message to the end. If we remember our cell biology, sends out a message, gets to the endoplasm, the Golgi bodies, the endoplasmic reticulum, and different proteins are fabricated in the cell, depending on what message it received to, hey, we need you to produce X. Right. And so those proteins are produced and they migrate to the cell wall. And that cell wall then basically creates a bubble. And some people call them exosomes, there's smaller ones that are microvesicles, etc. But that bleb or that balloon develops, and then it's filled with the cargo that was produced by your endoplasmic reticulum. And when you and I went to medical school, And, we were taught that that was all cellular debris. Well, it turns out it's not cellular debris. It's made on purpose. So you get the components that you'll see in an exosome are microRNAs, growth factors, peptides, all different types of different chain lengths of proteins. And they go into this little bleb or balloon, and then it seals off, and it's 1/1000th the size of a cell, so extremely small. And then it drifts off, and it basically, if you can think of it, follows the breadcrumbs. And what do I mean by the breadcrumbs? The signal, the inflammatory signal. So whatever the signal was that went to the recipient cell, and that recipient cell made the different proteins that are in this exosome. That exosome now follows those inflammatory breadcrumbs to go where it's needed. And that's called chemotaxis. Okay. And so that's the exosomes. Now, when we talk about stem cells, what are stem cells?
Let me interrupt you 1 second, because I think there's a clarification, and you just said something that I thought was great. So basically, an exosome is a cargo carrier from a particular cell.
Correct.
And an exosome from X cell may be vastly different in its contents than an exosome from Y cell.
That is correct.
Okay. All right.
And X cell can produce, depending on what instructions it received, it may produce several different cargoes for different exosomes, right? So it could produce multiple exosomes from one cell.
Okay. And so when people talk about, well, we're going to use exosomes, they're really kind of stripping away everything except the exosome. They're not getting the benefit of the symphony.
No, they could be getting the benefit of the symphony. It all depends. So this is where it gets a little challenging. So depending on the signals that X cell, the production cell, let's call it the production cell, the pharmacy cell. How about we'll call it a pharmacy cell. That pharmacy cell, just like, you and I call in a prescription. So, excuse me, I thought I shut this off. So the pharmacy cell sits here. Your body receives signals, and we'll call those the prescription, right?
Right.
So the prescription of other proteins come to X pharmacy cell and say to X pharmacy cell, I need VEGF, I need transforming fibroblast growth factor, insulin-like growth factor, I need microRNA 234, 365, etc. And so that instructs the cell, the pharmacy cell, okay, I'm going to go produce these, and I'm going to load them into these cargo carriers, the exosomes or microvesicles, and then they shoot off and go to where they're required.
And that begins the chemotaxic process. They gravitate to these areas of inflammatory, or more inflammation than less inflammation, or where there's tissue damage.
Exactly.
Okay.
Exactly.
All right.
You're spot on.
All right. All right. So now let's continue on with what you were going to talk about before I interrupted you about exosomes.
No, but I thought we have one thing everybody needs to understand. As human beings, our trillion cells are constantly producing exosomes. So all of our cells are talking to each other. Okay?
Right.
So the newest thing in diagnostic medicine is capturing exosomes to make very early diagnosis of different diseases. So cancers, breast cancers produce a very distinct cargo of exosomes with surface markers, so that you can, if you have the right equipment, you can pick up out of the blood that those are circulating, let's say, breast cancer exosomes. And so, and there's even from the tears, you can pick up some of the exosomes. And so there's a big field now of looking for biomarkers, which are basically exosomes in the adult, to make liquid biopsies, basically. Instead of
Right.
having to go in surgically and remove something and look at it histopathology, we can now, and this is a tremendous growing field, looking for these exosome biomarkers to make very early diagnosis of pathologies in us as adults. So we have to be very careful when we talk about exosomes that we're talking about either cultured, basically cultured cells from placental or pretty much placental mesenchymal stem cells. We have to differentiate what the sizes are, because we have come to determine that if we look at 50 micron to 150 micron, those tend to be the healthy exosomes derived from mesenchymal stem cells, whereas some of the disease biomarker exosomes tend to be on the larger size, typically over 200 microns.
Okay.
So I want people to understand that, there's healthy, good, regenerative exosomes, but there's not to be confused when we're looking at disease carrying or disease marker, not disease carrying, but disease marker exosomes. All right. I think that's an important distinction people should have in mind when they're talking, oh, I'm going to treat you with exosomes.
Right. And how does one, if they're looking into the exosome space, how do they differentiate to make sure they're getting what they want to get?
So that's the quality of the lab. So and there are several other labs like ours. We are built based on a what's the FDA 211 standard, that where we produce product based on as a drug, a pharmaceutical grade production, where everything is tested every step of the way. We have a very robust quality system to ensure that every dose is within a certain range, so that it's consistency from dose to dose. So it's all about how it's manufactured, where it's manufactured, what type of facility it's manufactured in.
Now, when you manufacture these exosomes, are you amplifying them, or are you primarily?
Well, yeah, so Chimera is a culture. They have a set of original set of cells that they continue to take through passages and then collect through a bioreactor the exosomes that those cells produce. That's one school of thought. I'm of the school of thought that we don't quite know enough yet to be able to have consistent, wide spectrum of all of the components that are necessary. So I like to use cells and tissue derived from pre-screened moms who undergo elective cesarean section. So we know a healthy baby was born from a healthy mother with a good medical history, good social history. And we know that because a healthy baby is born, we have the full symphonic orchestra of all of these components. Whereas, another company that does culturing, we don't really know. And this is not a dig, this is not a negative. It's just two different schools of thought to achieve the same goal. Do the exosomes that are produced via culture and expansion, do they have the same spectrum of components in each of those exosomes as we do when we gather them from a healthy baby that has just gone through 9 months of gestation? Nobody has the answer to that. And again, we see good results with a cultured product, and patients are responding positively. Patients respond extremely positively well with sole source, like I do. There's nothing negative. I just want to point out that we have more to learn to understand what's happening in the culturing procedure to ensure that you're getting the same spectrum of cargo.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pot of Inquiry. Use Pot of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Right. So let's touch on microRNA and peptides, because those are hot topics right now, becoming hotter as we speak.
Yes. So we're learning there's approximately 233 different microRNAs that have been identified in the amniotic fluid and Wharton's jelly and circulating in adults. And we know that there's certain microRNAs that are very specific to, let's say, cardiomyocytes and rehabilitating a heart after a myocardial infarction, or having influence on stabilizing a patient with congestive heart disease. I had done some work with Zane Calpe, cardiothoracic surgeon in Arizona, where there was some very promising outcomes when these items with the patient's informed consent were infiltrated into the septum of the heart when they were they had extremely low ejection fractions, and then we saw over a period of days that their ejection fractions improved quite dramatically.
So microRNA, basically, for the audience to understand, is really kind of a signaling mechanism to it.
Correct.
It gets transported into the cell, and then it plugs in, and that allows that cell to make proteins that were either underproduced or not produced.
Correct. And it appears that they're having functionality in repairing the mitochondria, the energy portion of a cell. Again, there's such a wide variety. We see, like with COPD, COVID, that there was a certain group of microRNAs that allowed surfactant to be produced, and there's a specific family of proteins that allow the small lung cells to function and exchange oxygen. And this family of proteins, when you increase the volume of microRNA, of these specific microRNAs to the lung tissue, we see this family of proteins increase and are very proactive in reducing the scarring and the fibrosis that occurs in the lung following either COVID exposure or the inciting etiology for developing COPD.
So if we look at this, and if we are only giving exosomes, we're losing some of the effect of some of the other things, or
in some cases. Now, orthopedic issues, if we get the right signaling, we use extracorporeal shockwave therapy, unfocused. We don't need the big EPOS machines like you and I started with. And I
Right.
still have that machine, by the way.
Okay.
It's an antique sitting in my office. But we can use these unfocused radial pulse type machines to get incredible inflammatory signaling going. And just using the exosomes respond to that signaling for orthopedic conditions, tendinopathies, fasciopathies, arthritis. We see quite dramatic improvements.
Let's talk about extracorporeal shockwave therapy, because I think when we first started infiltrating platelet-rich plasma, there was some debate. Do we want to use the extracorporeal shock wave before we put the platelets in, or do we want to do it afterward, after we've infiltrated the platelets? And my premise was that we would do it afterwards to create a lysis of the platelet so that it could spill its goodies, so to speak. And we did very well with that. Other people felt, well, no, you should do it at the beginning to signal things. So let's talk about that just a little bit, because I think ESWT still has a big role.
Oh, it does. There's no question. Again, signaling is key to all of this. We have to, if you think about most patients, heel pain, Achilles pain, since we're focused on the lower extremity, but it affects rotator cuff, golfer's elbow, tennis elbow. It's all about the signaling. Most people, when they get injured, what do? The first thing they do, they go and take a non-steroidal anti-inflammatory, Motrin, Naproxen, Celebrex, Mobic, whatever. And that changes the regenerative response. It basically almost shuts it down. And you're forming, at those injured areas, you're forming mixed collagen scar tissue, poorly formed, and then you're susceptible to re-injury. So what do we have to do? Patient comes in, they've been doing everything at their home care themselves, and they're not better. So we need to take it from a chronic state, this poorly formed scar tissue, fibrosis, and we need to get it inflamed, bring it to an acute phase, so that now when we add in our PRP or our allograft, our placental allograft or our exosomes, that it can now respond. It's now responding to the signaling. So we're both right as far as ESW2. What I have found is we need to get that pre-treatment shockwave going, and then we need to maintain the signaling. So we need to maintain the signaling by either the patient actively rehabilitating, but as you know, and I know from our years of experience with patients, they're not the most compliant, right? They think, oh, the doctor did his thing and it'll get better without me participating. So that's where I say we have to have continued, if they're not an active participant patient, then we have to keep doing the shockwave at least once a week after the biologic treatment to maintain that signaling through the rehabilitative phase of about 8 to 16 weeks.
Let's talk about administration. And so there's intralesional administration, where we're actually injecting like your flowable or, that type of thing. There's really now a surge in IV circulating these pro-growth factors, pro-regenerative factors is really probably a better way to say it. And they seem to, like you said, they seem to circulate throughout the system, but they have the chemotaxis to the area that really is where you need them. So if let's say a patient comes in for a plantar fasciopathy, that's probably the most common thing that our audience would use these on. You're saying that, all right, we signal it with the extracorporeal shockwave therapy. We administer let's call it infiltrate right now. We'll talk about what to infiltrate in a little bit. And then we continue with a ESWT treatment once a week for how long?
If they're not compliant patients, they're not active patients, I have them come in probably twice a week for 4 to 6 weeks.
Okay. And then during that 4 to 6 weeks of the extracorporeal shockwave treatment, are you bumping with another dose of the infiltrate?
No, no.
Okay. All right.
So let's talk about where to place the infiltrate. So what we have found, and I did my master's thesis on this, is think about, we've all been taught to inject cortisone intra-articular.
Mm-hmm.
And if you go back through the literature, you really can't find any studies that talk about why we're injecting this intra-articular,
Right.
right? It works, but it's fairly short-lived. And it ultimately, over time, we're learning that it's actually destructive to the chondrocytes, the cartilage.
Right.
So what we looked at was injecting periarticular and peritendinous and perifascia. And why? Well, think about the blood supply. So let's talk about tendon first. So if we inject along the paratenon, the circulation goes from the paratenon into like a capillary flow into the structure of the tendon, which is like cables, correct?
Right.
And so if we inject in a bolus into the tendon, it disrupts this whole capillary flow of micronutrients to the tenocytes. But if we inject around the paratenon, around the tendon, these micronutrients and growth factors and microRNA and the exosomes are able to get absorbed into the paratenon, go into the capillary distribution, capillary bed, and then into the appropriate cellular mix. And we see, we did a couple of studies that are unpublished, that's how we get the best biodistribution. So if we think about for bone and cartilage, where are the chondrocytes growing from? They grow from the subchondral plate. They're not growing and they're not fed from the synovial fluid, as we were initially taught that there's no nutritional supply and there's really no vascular supply. And if you think of the cartilage plate, it's like our skin. It has about 7 layers. And so the most robust are right attached to the subchondral plate. And you can see on histopathology slides, if you look at the subchondral plate from the cancellous bone to the subchondral plate to the attached chondrocytes, you see there are little tunnels, or I think tunnels is probably the best way to describe, of vascular supply going into the growing chondrocytes. So really the optimal, but this is not real practical, is to inject into the cancellous bone, go through the cortical bone with your syringe or your Jamshidi needle and inject the infiltrate right there, because that's going to have the most impact on chondrocyte development. Obviously, that's not practical or feasible in many cases, and there's associated risk. So why not go around the blood supply, the periosteum of the end plates of each joint, so that the micronutrients of the infiltrate get absorbed into the bone, go through the cortical bone, into the cancellous bone, and then feed into the end plate, the subchondral bone, and the chondrocytes. And so that's what I did my master's thesis on, was this circulatory pattern better than injecting intra-articular, where we're really, yes, we're getting improvement because we're decreasing the inflammation of the capsule, the synovium, and we're getting better, more viscous synovial fluid, but we're really not affecting the chondrocytes, which is our ultimate goal, is try to regenerate them.
Right. And that was one of the things conceptually I had a problem with intra-articular injections of PRP or amnio, or let's call it allograft, is that you're right. I mean, this cartilage isn't really getting its stuff from where you're putting that intra-articularly. And with a steroid, you've got the unwanted chondrolysis oftentimes. And so now you're just taking this joint that is pathologic and making it more pathologic by that type of administration. And I really didn't see, when we were playing with platelets in intra-articular application, I really didn't see much of an effect at all, quite frankly. What's your thought process on somebody that has a little bit of osteonecrosis?
That's a different story. So if we have, let's say, burnt hardy, stage 3, 4, or an AVN, let's
Mhm.
say like a Freiberg's and a second Met. This is a more, we need the surgery with the biologic, right? So we
Right.
need to be able to, like I was saying before, we need to get into the cancellous bone. We have to get angiogenesis. We have to get the circulation back to that tissue. With burnt hardy, yeah, we're going to have to go in arthroscopically. We're going to have to microfracture. We certainly can drill into the subchondral plate and implant some of our biologic. And then obviously we have to close it up. We can use juvenile crushed cartilage and with some fibrin glue. Some people have used, and I have as well, taken amnion membrane. So I've done my microfracture, I've infiltrated biologic, then I take the membrane, I use some fibrin glue and put it on there. The membrane is going to kind of dissolve over the course of 4 to 6 weeks, so it's not it's not going to create a meniscoid body or anything like that.
Hmm.
So that's how I look at how, if I were to be able to go back in my practice 20 years and you have this knowledge, I would have. This is how I would have dealt with these issues in the past.
Right.
I would have changed my techniques.
Well, I think there's an evolutionary process to everything.
Certainly.
And then there's always the conundrum that, well, what's been working clinically may not fit the academic thesis in lockstep, but yet these folks still get better. But maybe they could have gotten better, if we had that additional knowledge to marry the academic and the clinical together. So it's as much as, like, and the experts in this space, the way I look at it is this is a wholly new frontier, and we're just barely getting out to the uncharted territory right now.
Oh, I absolutely agree. And that's what's so exciting about being in this regenerative field now, is that I'm seeing I'm understanding mechanisms of action, and we're learning, we're understanding how these things and how we can apply them differently for our patients from where we were 10, 15 years ago to where we are today.
Right. Have you noticed how PRP seems to be making a resurgence now? I find that very interesting. It's kind of like fashion. I've got all these old ties in my closet, and my wife tells me, just hang on to them because they'll be back in fashion here, in another few years or so. And it seems like that's the deal with PRP right now.
Yeah, it's a 15 to 20 year climb, right? When you and I were doing it, they looked at us like we were a medicine doctor, like we were witch doctors.
Right.
And now it's mainstream. Oh, PRP.
Right.
And I see the same happening with the placental birth tissues and the cultured exosomes. Is we're on a cutting edge. It's going to, and it's been about 10, 15 years. You see, when I was like the only one speaking on this, and people looked at me like I had horns, to now there's multiple speakers at every conference on regenerative medicine.
Right.
And the same happened with PRP. When we both were talking about PRP early on, people looked at us, that's crazy. But now, like I said, it becomes mainstream, and I see the same with birth tissues, and then there'll be the next step is going to be some type of gene editing, or being able to pick out the correct cargo and create these exosomes specifically for a tendinopathy or fasciopathy or kidney disease. I see that this is where the future is marching to. But again, it's always a 15-year delay from when people start using it to when it becomes fully accepted.
So what do you think now about IV administration for some of the more systemic applications? Where are we in that arena now?
I mean, certainly every organ system is somewhat different as to how it applies. But what we found, let's say, just in our first study with wounds, was that when we originally thought, oh, if I treat one foot, I can use the other foot as my control. And that didn't pan out because both feet healed at the same rate. And we also found when they had wounds elsewhere in their bodies, let's say a sacral or a buttock wound, they all healed at the same rate. So what we learned was we can just inject these allografts in the butt or in the arm, and they're going to go where they need to go, and they're going to work. But there is a psychological component for the patient, especially with orthopedic conditions, that we want to treat them more locally, so that the patient visualizes that we're treating what hurts them. So that's for the orthopedic. When we're talking about central nervous system, and starting to advance care for post-ischemic stroke or some neurodegenerative diseases, we need to be able to apply these allografts more closer to where they get absorbed. So let's say like a sphenopalatine ganglia block, or there's some other blocks where you can go through the mouth. This is not my area of expertise, but the point is, for central nervous issues, we want to get it closer to the blood-brain barrier to get a higher dose absorbed that passes through the blood-brain barrier. When we're talking about kidney or a lung, IV works well. When we're talking about liver, there's still nobody's really established a great approach, though there's several very good case series where they have treated cirrhosis of the liver via IV. Though when you look at the circulatory patterns, you have to use a much higher dose because most of it gets picked up in the spleen or the lung. Some people have suggested injecting onto the, under ultrasound, injecting near or under the liver, the biliary ducts. Again, not my area of expertise, but I've heard these talks, and people, certainly people are exploring. We did, one of my nephrologist colleagues had done a small cohort of kidney patients in stage 3 chronic kidney disease, and with 2 doses, they had a lasting improvement in their electrolytes, BUN, creatinine, glomerular, GFR, glomerular filtration rates. And unfortunately, that study ran out of money and it couldn't be completed, but the preliminary results were quite significant.
Well, before we wrap this up, let's talk about the FDA, because that's one of the questions I always get. What about the FDA and these regenerative technologies? Because there's been kind of an interesting historical pattern with this.
Right. So the membranes are still considered human tissue, human transplant tissue, and they're 361, and nobody seems to have any issues using these amniotic membranes.
Is that because of minimal manipulation?
Correct.
Okay.
Minimal manipulation, and they're pretty much being used as a barrier, so it's homologous use. When we're looking at the liquid products, though, this is more challenge, and we have to ultimately get a biologics license. And the process for these amniotic fluid, exosome products, the amniotic fluid, Wharton's jelly combos, all these different placental-derived injectable allografts or liquid allografts need to go through this process. We need to get an investigative new drug application filed. That's called an IND. They have to approve in that IND, we have to show them what is the chemistry, the mechanism of action, how are we manufacturing? Are we manufacturing to a pharmaceutical standard? And what is our controls? What is our quality system to ensure that there's consistency of dosing? And then we have to provide a clinical trial protocol, and this is all part of the IND application. It's fairly extensive, a lot of data, lots of information that gets submitted to the FDA, and then once they approve that, and several products are in their early clinical trials, and then once you get through phase 2 and 3, then you submit your data for review, and then everything's approved, then you can apply for a biologics license, and there's a fairly hefty fee associated with that. Once you get the biologics license, then you can make specific marketing claims based on what your clinical trial was about. So that's the FDA process. That's what BioXtek is in the process of doing, all of that to achieve a biologics license on several different pathologies.
That's a very arduous and expensive process.
Yes, it is.
So,
and lucky for me, after all these iterations that I've gone through over the years, I've brought together some impressive strategic investors who see the long vision and understand that this is the way, this is the path forward to bring these type of regenerative products to the market, out from underneath the shadows into the mainstream.
how long do you think it's going to take you before you get to that point? I mean,
well, if all the stars align and the gods are blessing me, the best case is 2 more years. Worst case is 5 or 6 years. Okay.
Well, it takes a lot of tenacity, and I laud you for that, because it's not an easy process. I had Sean Berman on, who, I don't know if you know Sean or not, but yep. his father was one of the pioneers in fat allografts, or actually autografts. And they actually went to trial with the FDA and won, which that's a big deal. It's like David versus Goliath, it's like, because that's hard. Anytime you see, the United States government, FDA versus XYZ corporation, that's probably not a good thing to take a look at, right?
No, that's a lot of heart pain.
Yeah.
No, but they won. It was a significant finding. Yep. And I've not seen that the FDA has filed an appeal, which I thought they were going to do. But it goes to the point that FDA cannot and should not be participating in the practice of medicine.
Right.
That they're there to make sure things are safe, but not participate in the actual practice of medicine.
Right. That's a whole different discussion where we could do with a wine episode where we have a glass of wine and talk about all of that.
Maybe more bourbon.
Yeah, bourbon, wine, whatever. But yeah. So Bruce, thanks so much for coming on. I mean, we just barely scratched the surface. I know we're going to come back and revisit some of these little points some more if you're kind enough to donate the time.
I enjoy talking with you.
And likewise, I always find it so educational when you can talk to me about this stuff. What I want to know is if the audience wants to get in touch with you, look at your all your work, where do they go?
Well, unfortunately, I can't publish current work until we've submitted all of our data to the FDA. But certainly I'm happy to talk to anybody. They can reach me at docw at bioxtek.com. So DOCW at BIOXTEK.com.
All right. We'll put it in the show notes. And I want to thank you again for coming on this morning, and look forward to our next discussion.
Absolutely, Steve. It's a pleasure seeing you again and getting to chat for quite a while. This was great. Look forward to doing it again with you.
Awesome. Based on the very positive and inquisitive feedback that I've received from my conversation with Dr. Robert Kornfeld, which was Season 2, Episode 4, which we discussed the integration of functional medicine into your podiatric medical practice, I wanted to share with you my personal experience and why you should really think about taking Dr. Kornfeld's excellent functional medicine course. Over 20 years ago, I quickly learned that we had to treat the whole patient, not just the symptom down in their lower extremity. But I did not have the luxury of being able to obtain something like Dr. Kornfeld's training course. I had to piece it all together. And truthfully, I am still piecing it together, as it is a constant and evolutionary process that will never end because new information is always becoming more and more available. But by taking his well-constructed course, you will have a strong foundation to continue that building upon. And oh yeah, maybe the best thing is that this will allow you to have the platform to launch out of the imprisonment of third-party insurance, which will improve your life. Think stress reduction here now, folks. And at the same time, you'll be able to optimize the lives of your patients. If you want to go from dysfunction to full function, start here right now. Functional medicine provides you with the powerful niche that will allow you to go into the direct pay model and be done with the insanity of participating with insurance. Go to his website now and tell him we sent you, because you don't want to be dysfunctional anymore. To get on board with this fantastic educational opportunity, go to Dr. Kornfeld's website, instituteforfunctionalpodiatricmedicine.com. That's instituteforfunctionalpodiatricmedicine.com.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.